So let's start by getting our definitions out there. So what is constipation? And I don't mean in a Freudian sense, but in a medical sense. What is constipation and what are patients going to tell us about what they're experiencing?
So there are various ways of defining constipation. I think it's most important to understand what's normal for the patient and really ask, do they feel like they completely evacuate when they go to the bathroom? Other definitions are kind of the rule of threes. Fewer than 3 bowel movements per week is abnormal. Normal would be 3 a day or 3 a week. If they're describing their stool as hard, dry, or lumpy, difficult to pass, again, feeling like they're not completely evacuating. Or some patients will actually tell me that they have to manually disimpact themselves.
So before we get into evaluating constipation, there are a few kind of red flags, key things to watch out for that may push us toward a more urgent treatment, so to speak. So what are those things?
So some red flags that I think about are severe abdominal pain with no stool for a prolonged period of time. And we might be thinking about impaction or even a bowel obstruction in these cases. If they have blood in their stool or a fever.
So turning from the red flags, which would lead us to punt, what questions do you usually ask in your history when you're seeing the patient in the office?
Yeah, I usually preface that this is going to be a riveting conversation between two people that don't know each other nearly well enough to have this discussion. But I want to get a good stool history. I ask about the caliber, the frequency, and the consistency of their stool. We'll reference scale a little bit later here. Their medication history, because a lot of commonly prescribed and taken medicines can cause constipation. We all are familiar with opioid-induced constipation, but thinking about antacids, iron, and then NSAIDs. And then what are their habits? What's their diet like? Do they have a good fiber intake? Do they drink a lot of fluid, exercise? Or have they even started trying scheduling defecation?
So Justin, what we're seeing here is not a menu at a fancy French restaurant, but rather something that you love to make new friends with called the Bristol stool scale. Walk us through this.
Yeah, and I would just say the pickup lines of our fathers and their forefathers pale in comparison to using the Bristol stool scale. And on this, we're kind of seeing types 1 through 7, depending on the consistency of stool. Since we're talking about constipation, we're really going to be focusing on types 1 and 2. I find that patients actually do resonate with this a little bit, and it can be hard to sort of deliver from them a description that's meaningful to me about what their stool consistency is like. So it doesn't hurt to have this in your office. So certainly if they're describing their stools as pellety or not really a uniform consistency, that is pretty consistent with obstipation or constipation.
We talked a little bit about some red flags earlier, but what would push you, so to speak, to refer the patient immediately for a colonoscopy? Like, this is a patient we need to get up and look in their colon and see what's going on.
Certainly if I'm concerned about colorectal cancer. And some risk factors for that are going to be age greater than 50. If this is an acute or recent onset associated with weight loss, if they're having abdominal pain or cramping, certainly if they have heme-positive stool or descriptions of melena, if they're so constipated that now they're having nausea or vomiting, that's pretty startling. We don't want to have any feculent vomitus in our office.
Negative.
Yeah.
Band name called it.
Oh.
All right.
And then certainly classically, if they describe a change in stool caliber like narrow or ribbon-like stools or tenesmus.
So turning from history to physical exam, what sorts of things and clues are you looking for on the physical exam in constipation?
So constipation, you definitely want to do a good abdominal exam. And I always have to kind of counsel our learners to actually do a rectal exam with this. I joke that I do a rectal exam on everybody, which of course isn't true, but I do think it's important to do in constipation because from it you might gain insight into if they're having hemorrhoids, an anal fissure. It's a good time to do an FOBT, checking for rectal masses or fecal impaction. I actually had a gentleman that presented with constipation and complaints of hemorrhoids and declined to have me do a rectal exam, and I gently persuaded him to let me, which felt uncomfortable. Lo and behold, he actually had a huge rectal mass that was not a hemorrhoid.
Oh, wow.
And unfortunately passed away from complications of having it removed. And on physical exam, I'm going to check for signs of anemia, conjunctival pallor, delayed capillary refill. We'll check for abdominal masses. If they have a palpable colon, that's pretty severe constipation. And then also check for hepatomegaly.
And I will just mention for clarity, FOBT means fecal occult blood test. So we don't have a asterisk there.
So a major pitfall that we can fall into, and thankfully this is rare, but loss of a sacral reflex, also known as an anal wink, suggests that the patient actually has a sacral nerve deficit causing their constipation. So I'm not in the habit of checking for that, but you and I were sort of reflecting that maybe we should be.
So Justin, any diagnostic testing, imaging, or labs that you routinely consider with constipation?
So certainly some of the underlying causes of constipation inform my diagnostic workup. So we want to check the thyroid with a TSH. Remember that calcium disorders can cause constipation, so I get a calcium level, or basically a BMP, a CBC to look for any signs of anemia that might indicate that this could be an underlying colon cancer, and then certainly getting a colonoscopy makes sense.